dive in. So Matt, and you've heard from both, everybody who's spoken so far, of what this concept of the exposome is. Measure as much as you can, if not the totality. We don't have to measure it all to make significant progress. I'm going to talk a little bit about how we're thinking about how do you measure all of the exposures above the skin and start to unpack those as they might be driving health outcomes, but also disparities. And identify stressors that impact health. So you heard about solution-oriented research. So we should be looking at, that's one way to start, right? Let's focus in on the health-relevant exposures. As I said, I'm going to use asthma as a disease paradigm because it's a very good one to think about when you're looking at early determinants of onset of disease. Asthma starts very early in life, about 50% manifests by age 3 years. It's getting younger and younger as we see more people living in worse and worse environments that are driving that, and about 80% by age 5. So we know there's something, as Matt already indicated in his talk, that starts very early in life. It's a multifactorial disease, right? It's complex genetic disorder, but it's also driven by multiple environmental influences. And that includes not only chemical toxins, but as Paul said, we have to think about social and policy level, and I'm going to touch on each of those as I talk about what I think is driving asthma disparities that we've seen. And what are the modifiable risk factors? What are resiliency factors, right? What are the levers where we can improve and not only make diseases better as far as manifestations and morbidity, but let's prevent it. I'm an adult pulmonary critical care physician, and so I take care of patients out on the right-hand side of this graphic of the life course. And I, in my own career, started thinking, how far back do I need to go to put people on a better trajectory? I was taking care of end-stage lung disease in folks, and I wanted to give them longer life with good functioning. And it took me all the way back to prenatal. That's where the roots of asthma begin, and that's what we're going to be talking about today. And there are multiple factors. The complex, we used to think about cigarette smoking, indoor allergen exposures, then we started thinking about air pollution and allergens, and the complexity of what factors are driving the onset of asthma has just grown and grown and grown over my career and understanding, to the point where it looks more like this. And I'll see if I can find the pointer here. They gave me a new, I'm not sure you can see it. But this is a graphic that shows when we think about the external environmental factors that we now know from the evidence base that's built over the last 2 to 3 decades of what's driving asthma onset and can trigger disease, even starting in pregnancy. It's the indoor environment where we've been largely focused as asthma epidemiologists, indoor allergen exposures, tobacco smoke exposure, these kinds of things, and pollution indoors. But we also then know it's also outside, the ambient environment and the built environment. So air pollution is one we're particularly looking at outside, ambient air pollution, but there's multiple factors there as well. And then it's your how you emotionally experience your social environment is also a toxin. It gets in the body, it can drive biology and change physiology, just as when you breathe in tobacco smoke or an air pollutant, et cetera. And so I think of it as like stress that we experience in our environment as a social pollutant. And think about, and that graphic, you start to understand, well, okay, now there are many, many things I have to start to measure. These are things I know that are driving the onset and manifestation of the disease. But how do you start to think about them together in kind of that toxic soup and unpack what's really driving the effect? And that might be different in one population or another that you're looking at. So your intervention is really going to rely on understanding within a certain population what the main drivers are and what do you do. Well, how does it start to affect you in utero? Because the baby's not breathing in air pollution and experiencing these things, but the mother is. And moms bring that, take in all of these toxins, whether it's social stressors, air pollutants they're breathing in, tobacco smoke, etc. And that's going to change her functioning, her biology. So it changes these key regulatory systems that are shown in the yin and yang diagram down in the lower right-hand corner of this graphic. And so air pollution, other chemicals, psychological stressors, they all push and pull on these key regulatory systems that keep us in a healthful balance. And they include, and they're not limited to, the 4 that I have there with the circles bubbling around the yin and yang diagram. So it's autonomic functioning, neuroendocrine functioning, the hypothalamic pituitary adrenal axis, oxidative stress, and all of these interact with the immune system, which is very key when you're thinking about lots of diseases, increased inflammation, immune disruption. But asthma is really a disease of disrupted immunity that can start to be based on what mom's experiencing, signaling through the placenta, that already starts to prime and program the child's immune system and other interrelated processes that involved in lung growth, development, and responses that the kid is going to have when they're in the world. And there are some review articles on some of that there. Matt already showed this, the power of echo now to allow us to look at the difference in incidence of asthma across different social determinants of health and socioeconomic and racial ethnic factors. And that's the other key thing that we've been grappling with as asthma epidemiologists or respiratory epidemiologists, is this disparities that we can't get our hands around. We've seen this for years. I've seen this through my whole career, and it's only growing, that there are certain demographics that are at higher risk: urban populations, lower income populations, and historically minoritized groups like African Americans in this country, but not limited to that. Here we were only able to look at African Americans versus non-Hispanic whites in this data set that we had, but it's really other Hispanic groups are at greater risk as well as other groups. So this is what we're trying to tease apart. Well, what are the environmental influences that are driving these recalcitrant disparities that we see in respiratory disease? Again, just like Moses on the Mount, we don't have to do it all. Let's start with these 10. And so I always kept that cartoon in my head. Well, what do I start with? What are the health relevant factors? How many things can we measure? And what tools do we have to look at it? And I'm going to start with the social, because this was something I was very interested in as a pulmonary fellow when I thought, well, what are we missing about these disparities? It's not, if we look at the usual suspects, allergens, air pollution, or tobacco smoke exposure, and even to some extent we were starting to look at ambient air pollution, it only seemed to explain 10 to 15% of the variance that was going on to display. So we're missing a huge part of it. And as a clinician, I always was right in front of me, the mind-body connection and this whole how emotional stress is really playing a role in my patients' outcomes. And so I got very interested in measuring stress and seeing how that might play a role in the onset of asthma, not just exacerbation of disease. So I asked the question, are children born to mothers who experience greater stress during pregnancy more likely to develop asthma? And this was in an ethnically and racially mixed and socioeconomically mixed population. And what we found was, in a dose-response way, whether we looked at prenatal exposure on the left-hand side of the graphic at the bottom, increasing number of negative life events that mothers reported experiencing in the previous 6 months during pregnancy, and whether or not their child went on to have repeated wheezing respiratory illnesses in early childhood. And I could map the same thing if you waited longer and followed them out and looked at asthma diagnoses. And then in the first 18 months of life, also a dose-response relationship. So both of those were critical windows where if you're living under high levels of stress, these kids are going to be at higher risk of developing asthma. And that was when you adjusted for things like measuring allergens in their home and measuring all these other factors that we were looking at. So it was independent of all those other factors. And then I started looking at air pollutants, and what you really could measure at the time are these criterion pollutants, which are the ones that the EPA is monitoring, and there's regulatory policy around to manage, maintain healthful levels. And so there are a series of air pollutants that you can look at, and particulate matter, and Matt mentioned that as well earlier in his talk, is one that has been particularly widely studied and predictive of respiratory disease. And so that was one of the ones we started with, although we've expanded on from there. And you're going to hear more about how to measure air pollution using stationary monitors, which are the dots on the map of the northeastern United States, which you see here, which are used to calibrate data that we get from NASA satellites, et cetera. Itai Klug is giving a workshop. Actually, he'll touch on some of these things on our second day tomorrow. And we use geospatial mapping that Matt also introduced. So link it to the address of where these women live during pregnancy, and we could actually come up with a daily level of exposure to air pollution, in this case particulate matter. And we could use data-driven statistical approaches, which are shown here with the results. And what I'm circling there is that what we found was that there was indeed a relationship between increased exposure to particulate matter, fine particulate matter, in mid-pregnancy. So that's plotted over gestation there. And where the circle is, it's around in the second trimester of pregnancy was seen to be the place where we found the greatest risk. And that was the first prospective study that was able to show that relationship. But if we're going to explain respiratory health disparities, and here we're looking at lung function in those same kids as we followed them out further in time and around age 6 to 7 years, and we found that levels of lung function tracked very much with their level of socioeconomic status and based on race, ethnicity. And in our population where we had non-Hispanic whites, white non-Black Hispanics, and Black Hispanics, we found that Black Hispanics had the lowest levels of lung function in certain areas, in certain communities, where it was the Hispanic Latinos that were more impacted in other geographic areas, even in our small catchment area in the northeastern United States. And to unpack that a little bit, we wanted to look at, well, is it because of variability in exposure to the air pollutants? And we didn't want to just look at PM 2.5. By now, our colleagues could give us more exposure data on other types of pollutants, so we could look at ozone, NO2, sulfates. We can look at a number of them now in constituents of that PM 2.5. And this map, this heat map of the whole northeastern United States, going from the dark purple, which are the highest levels of exposure, to the areas where there's yellow, where the lower levels of exposure. You can see that geographically they're very differentially distributed. We wanted to start to understand if that mixture was of interest, and the different mixture of pollutants that occurs in these different geographic areas could help us understand what the major drivers were and how they might differ based on that geography. This also underscores the power of programs like ECHO, which is going to actually give us the whole United States. We're just looking at a piece of it here, and even here we can see that it's important to understand that mixture of multiple pollutants. Embracing a little bit closer to this idea of the exposome. So let's measure as much as we can, and maybe it'll give us a little bit more information about what might be driving things there. And there are lots of tools and methodologies that are coming that allow us to do that. But then you think about disparities, and we talked about social policies and how much of that do we have to think about when we're putting these things into context, the context in which these people are living, going to school, working, et cetera, in these communities. And it's very important, because if you look at policies that drove practice of investment in these communities, and making home loans so people could own homes in these different communities, it wasn't by happenstance. So there was practices put in place in the earlier part of the last century that actually graded these communities, and largely it was based on how the percent minorities living in those communities, particularly African Americans, but also others. And best is in the green. Blue purple is still desirable. In the orangish, it's definitely declining or starting to decline. And the red is the hazardous. This is where they did not want to make loans and disinvested in these communities for years and years and decades. And that's this redlining policy, and that's why that's in red. And you can see today, I mean, the redlining communities, those gradation and the colors are on the left-hand panel, and then I'm showing you a heat map of various air pollutants that are there. And you can start to see that it's not by chance where these toxins seem to land. It's not by chance the social circumstances that increase the number of stressors that you're experiencing living in those communities as well. And a major one is community safety that we can track. Community safety, exposure to crime, violence, these sorts of things has become a major social determinant of health that we're all looking at as an indicator of this disinvestment in these communities, if you will, but it also is a stressor. If you're living in communities where you feel unsafe, uncontrollable, unpredictable, that's what stress is. And this was a paper we did where we looked at community level exposure to violence, not direct exposure, but just knowing about the levels of violent crimes in the neighborhoods reported by pregnant women on the left-hand side, predicting, again, repeated wheeze in early childhood. You see a dose-response relationship. And if you have air pollution in the same model and you're adjusting for it, it's also independently predictive of respiratory disease. Same magnitude of effect, but they're in the same, they're both important. That's what we were seeing there. We didn't have enough power to say, where are their synergies? Does it magnify? Does one magnify the other in any particular way? And that's the power of ECHO. We have bigger and bigger data, we'll be able to ask and answer those kinds of questions and have the power to do that. Well, why do we want to measure both social and chemical stressors? Beyond that, because they are synergistic in some situations. And this paper suggests that it's really the kids born to mothers with both high prenatal stress and high exposure to the air pollution where you're really seeing the effect. Pretty flat on the left-hand side where moms aren't experiencing a lot of stress during pregnancy. And here's a paper that one of our colleagues, Mariel Guerin, has mapped for us. She's looked at both on the right-hand side, PM 2.5 level exposure based on race, ethnicity, white in the yellow, black in the orange, Hispanics in the pinkish, and then the other category there. And you can see that you get increased if in minoritized populations, again, we're seeing increased exposure to the PM 2.5. On the left-hand side is an indicator of neighborhood safety index that we've created using extant administrative databases, particularly things like crime exposure in those communities. You can see that they also they have lower levels of neighborhood safety. Lower levels are less safe neighborhoods, less desirable neighborhoods. And then we looked at cumulative effects of the PM 2.5 again, whether or not you lived in a safer neighborhood, the high NSSI on the right, versus a less safe neighborhood. And you can see you can't really measure the effect of the air pollution if you have a toxic social environment. You can only see the effect of the air pollution on top of what's happening in the neighborhoods that have good social environment. So that tells you, well, what's the lever? If we do something about air pollution, is it going to affect asthma at all? Probably not. We're going to have to do something about the social environment, and we need to understand what it is about that that's driving it. And that more and more people are seeing that kind of relationship. So that's an interesting concept to hold on to. It doesn't always work out that way, but we're seeing a lot of it. And then I want to follow up on what Matt talked about with solution-oriented research to think about this randomized clinical trial that I had the opportunity to participate with a group down in at Johns Hopkins. So they were running this mobility asthma project that said, if we move kids out of the inner city, kids who have very severe asthma, exacerbation-prone disease, if we move them out of those communities that we know are toxic from all these reasons, will they get better? And is it because we make their chemical environment better? So they go into the homes and they actually measured air pollution exposure in those homes. They quantified the levels of allergens, both pre and post move. But they also reached out and asked me, because of some of the work we were doing, should we measure stress? Should we measure neighborhood safety? And so you start to see this notion of why we need transdisciplinary and interdisciplinary teams to do this work. So that was great, and I said, oh, that'd be fantastic if you put that into this type of randomized clinical design. And this paper just came out in JAMA, and it's one of my favorite papers. I mean, they did all the work. But again, you see on the left, this is Baltimore, and you can see that a lot of this red-line communities, a lot of these kids with poorly controlled asthma were coming out of those red-line communities, and they moved them. On the map on the right shows you they went to more higher investment communities, better housing, less dilapidated housing, lower crime, better safety indices, better pollution, et cetera. And we measured, again, respiratory outcomes and survey measures, including at the bottom there, neighborhood social cohesion, safety, and then we measured psychological functionings in the moms and the kids. Well, exacerbation significantly lowered after moving. When they looked pre and post, that was very significant. There was 54% reduction in odds of asthma exacerbations after moving. Now, this effect size is larger than the effect of inhaled corticosteroids, mainstay of treatment for asthma, 43% is what they see there, and similar to that observed for biologic agents, which we use as clinicians to treat these things, 50% or even higher. So you get a similar effect from this social intervention. And then they looked at what mediated the effects. You know, air pollution levels went down pre and post. They could show that allergen exposures went down pre and post, and also stress went down pre and post. And then they said, what mediated most of the effect? Most people had been betting on the chemical exposures, the physical exposure, and it wasn't. It was the social cohesion and daytime and nighttime safety that was driving effect. Indeed, neighborhood cohesion, safety, and reduced urban stress explain between 1/4 and 1/3 of the effect there. It's a huge effect on what was going on, suggesting that interventions that seek to address the legacy of structural racism in housing, other policies, are strongly positioned to result in health benefits in children, not just with asthma, with other things. This is a small trial. We have to start doing these kinds of studies, asking these kinds of questions, and incorporating all these things together. Now, ultimately, it's going to be great to do multidimensional omics assessments as what's the biology, how did the biology change? And we're doing epigenomics, metabolomics, proteomics, immune phenotyping as part of that. But to Matt's point, we have got to go upstream and figure out what the drivers are if we're going to have any impact down the road. And that's the power of ECHO, which I'm showing here. I mean, and I'm part of ECHO. We're in the first 7 years. We've just started the next 7 years to continue to recruit during pregnancy and follow these women. And I'm very excited to have the opportunity because, you know, when I'm taking care of people out at the end of their advanced disease, it's easier to build strong children than to repair what you're dealing with then. You can't make too much bang for your buck, but we could actually prevent disease if we really embrace the power of the exposome. So I want to acknowledge that it is a team, it is a multidisciplinary team, and this is just some of the folks that helped on what I presented here today and some of the funders, including ECHO. So thank you very much.